For me, it's a great pleasure to introduce Professor Jonathan Barratt as the invited speaker, the main speaker of our Congress. You know that in IgA nephropathy in the last years, several exciting, very important papers have been published, publishing different new treatment for the disease. I think that we are in a change, in a dramatic change in our understanding of the pathophysiology of IgA nephropathy, and probably more important, new therapeutic possibilities. And Professor Jonathan Barratt has been in the center of these discoveries. He has played a fundamental role in the intellectual development of these new treatments targeting different pathogenic pathways. So I think that Professor Barratt is the ideal person to cover the topic of this lecture, new treatments in IgA nephropathy. So John, thank you very much for coming. It's a privilege to have you here. Please.
Thanks very much, Manuel. It's a real pleasure to be here, and it's absolutely fantastic to see a room full of people interested in glomerular disease. I feel very much at home here. It's really great to talk about IgA nephropathy. There's been a lot happening, and what I'm going to do over the next 20 or 30 minutes is just take you through the changes that are happening and really give a challenge to the younger nephrologists in the audience that you're going to have your work cut out trying to work out how to use all of these wonderful new therapies we're going to have that I didn't have and Manuel didn't have when we were looking after patients with IgA nephropathy. So here are my disclosures. So I want to start off by telling you the scale of the problem. I think if we were all going to talk about glomerular diseases, we would get very worried about ANCA-associated vasculitis. We get very worried about class 3, class 4 lupus, C3G, atypical HUS. But when we think about IgA nephropathy, we've traditionally thought it's a pretty benign, slowly progressive disease. We don't need to worry about it very much. And what I'm going to show you from this data that we published recently is that is absolutely not the case. So RaDaR is the Rare Kidney Disease Registry in the United Kingdom. It's the largest rare disease registry in the world. It has between 25 and 30 different rare diseases, and IgA nephropathy is one of those. And because of our healthcare system, every time a patient who's registered in RaDaR has a clinical encounter, has a blood test, has a urine test, that data is automatically downloaded into the registry. So we have lifelong follow-up. We know about dialysis, we know about transplantation, we know about potential medication changes, and we are going to have, ultimately, the general practice record in there as well. What I'm going to show you is the outcomes in the UK for patients with IgA nephropathy in our first analysis of this registry. And this is over 2,000 adults and close to 200 children. And so what you can see here is the high-level data. So if you look here, let's see if there's a, oh, good. Okay, so if you look here, this is the overall outcome. So if you are a child diagnosed with IgA nephropathy in the United Kingdom, at 20 years following diagnosis, half of those children on dialysis have developed kidney failure. If you are an adult diagnosed with IgA nephropathy, at 20 years, 3/4 of those adults have developed kidney failure. Now, when I show this data in the UK, and it's our data, the nephrologists are thinking, that can't be right. But it is our data. If we now look here on the left-hand side, what you will see, so this arrow here is how old I am. So I'm 55, and I still think I'm quite young. And I can see people laughing, thinking that I'm not that young, but I still think I'm quite young. I quite enjoy not being on dialysis or having a kidney transplant or having CKD. The kids are off to university. Me and my wife can finally go away and spend some money, and we can have a great time. So this is me. So if you're a child diagnosed with IgA nephropathy, by the time you reach my age, 3/4 of those children have already developed kidney failure. If you are diagnosed between the ages of 18 and 40, 2/3 of those adults have developed kidney failure before they reach my age. And I think that's an absolute disaster. It may take a long time, but 55 is no age. And if we are not managing our patients and accepting a 20-year outcome is a reasonable outcome to avoid dialysis, we mustn't forget that our patients are young and they're going to end up on dialysis, the majority of them, by the time they reach my age. So this is something we did with the data from RADAR, and this is something any of you in the room can do. And I always, when I'm doing this in slightly smaller groups, I ask who the trainees, the fellows are in the room, because this is something that you can do very easily. What we did was we took the GFR at the time of kidney biopsy. So the first time we as nephrologists really get our hands on patients. And we said, what rate of loss of kidney function must that young person have for the rest of their life to avoid kidney failure in their lifetime? And so what you can see here are the ages at the time of diagnosis, and you can see the rates of loss of kidney function that we calculated, the risk of kidney failure in that person's lifetime. And so what you can see here, if we just go to the next, is if you're diagnosed between the ages of 18 and 30, unless you get down to a rate of loss of kidney function of 1 ml per minute per year for every year for the rest of your life, then there is upwards of an 89% risk chance that you will get kidney failure in your lifetime, based on the GFRs of our patients at the time we make a diagnosis and can start intervening in their care. And what you can see here is that really patients need to be achieving extremely low rates of loss of kidney function for the rest of their life if we are truly going to give them a chance of avoiding kidney failure in their lifetime. And the reason for this, as I'm sure you all know, is our patients present late. Certainly in my practice, my patients come to me not really understanding why they're seeing a nephrologist because they feel fine, but someone has found blood and protein in the urine, or someone has found they've got a high blood pressure, or their blood test, their creatinine is not quite normal. But they feel fine. They're not coming to me because they feel unwell. And because of that, they present late. If we look at all of the series from across North America, Europe, Asia, the average GFR at the time of presentation is between 50 and 60 mils per minute. And what that tells me is the patient sat in front of me has already lost at least 50% of their nephrons. For that creatinine to have changed and that GFR to have fallen, they have lost at least 50% of their nephrons. And what that means is we do not have time to wait to start treating these people. We've always known that more proteinuria, the worse the outcome. And what this data tells us is that the extent of proteinuria predicts how quickly someone is going to develop kidney failure, not necessarily whether they will or not. And we have always known that higher levels of proteinuria, here you can see greater than 2 grams per day, here you can see greater than 1.5 grams per day, are associated with a worse outcome. But what RADAR did, because it has such large numbers of patients and long follow-up, if you look here, 0 to 0.5 gram per day, 0.5 gram per day to 1 gram per day, at 10 years, 1 in 4 of those patients has developed kidney failure. So this idea that we don't need to worry about IgA nephropathy unless the proteinuria is above 1 gram per day clearly needs to be challenged. And I've just reviewed a paper that will be coming out in NDT shortly from Sweden. And Sweden has a very similar healthcare system to the UK, which allows it to do population-level follow-up. They've been looking at the impact of microalbuminuria on the risk of kidney failure in IgA nephropathy. So we are talking about low levels of proteinuria being highly significant in a young person in determining their future risk of kidney failure. So if you take anything away from this talk, it's that when you see that patient with IgA nephropathy, you shouldn't think 5 years, 10 years, 15 years, 20 years, because they're still going to only get to my age. We need to be thinking about their lifetime risk of kidney failure. And yes, things don't happen as quickly as they do in ANCA vasculitis or lupus nephritis, but kidney failure is kidney failure. And if these people are developing kidney failure in their mid-50s, that is a disaster. So we are all nephrologists in the room, and our job is to save nephrons. If we don't save nephrons, we are doctors of failure, because we look after people on dialysis, and we look after people with kidney transplants. And those patients have developed kidney failure. So we need to think, when we see that patient sat in front of us, what can I do to save nephrons? Not next year, but today. And to do that, we need to understand what is driving nephron loss in IgA nephropathy. So we have those IgA immune-specific factors, IgA immune complex formation, deposition in the glomeruli, inflammation and scarring, that absolutely cause nephron loss. But just like any other disease, as we accrue nephron loss, those maladaptive responses start developing in the remaining nephrons. Glomerular hypertension, glomerular hyperfiltration, the impact of proteinuria on the tubulointerstitium, the impact of systemic hypertension. And so we have this other factor that is driving nephron loss. And this is a very stylized diagram, but what you can see is that over the natural history of the disease, as we lose nephrons, the likely contribution of these is going to vary. But they both drive nephron loss. Now, it would be perfect if the minute IgA starting deposited in the glomeruli, patients complained and came and saw us. Because we'd be able to treat at this point, there'd be little nephron loss already, and we would be able to manage just the immunology of this disease. But as I've said, certainly in my practice and commonly, patients present late, often by chance, in which point they have already accrued nephron loss, and therefore these processes are occurring while also having an active immunological disease. And we must address both of these if we are going to avoid kidney failure in the lifetime of our patients. So what did KDIGO say in 2021? So this was the culmination of 50 years of research into how to manage the world's commonest glomerular disease. So it's pretty underwhelming reading, I have to say. You could probably have picked out what we would have said if you were a final year medical student. Because what did we say in a proteinuric kidney disease? We control blood pressure. We try and reduce proteinuria with a RAS inhibitor. We modify lifestyle and we address cardiovascular risk. All the things we do in general CKD. But where's any of the disease-modifying therapies? Where's the ability to manage the immunology? Well, for most of my career, this is where it's been. This is the remaining IgA glomerulus flowing across the thing. For most of my career, I would sit in my room and the telephone would not ring. There would be no interest in new therapies in IgA nephropathy because it was too difficult to study. Because if you have to know, the only way you can know whether a drug works is whether it impacts on a doubling of serum creatinine end-stage kidney disease or death, you'd have to follow large numbers of patients over many, many years to know whether your drug worked. And that was just unaffordable for drug companies. What changed was that we were able to start using surrogate endpoints. We were able to look at proteinuria at 9 months to get a drug approved. We were able to look at GFR at 2 years to get a drug fully approved. And what that did was it catalyzed the pharmaceutical industry to be interested in IgA nephropathy. One of the other things we did in the KDIGO guidelines was we actually made it completely acceptable, because we acknowledged we didn't know what to do, to put patients into a clinical trial. And we have had a fantastic global response to the clinical trials we've run. We have recruited all of them to time and target, even in the setting of a COVID pandemic. And so we have had an absolute explosion in activity, and that's what I'm going to talk about for the rest of my talk. So let's get back to what we want to achieve. No kidney failure in the lifetime of our patients. We must address both drivers of nephron loss, and this is our target. Oh, my pointer's gone. The target of GFR loss that we want to achieve, as close to 1 ml per minute per year loss as we can. So we're absolutely going to need to continue optimized supportive care. That's what we do. That's going to protect against those generic drivers of nephron loss. We've had RAS inhibitors. We've now got SGLT2 inhibitors. And we know from the DAPA-CKD and the EMPA-Kidney trials that IgA nephropathy patients behave identically to general CKD patients. And so these are being more commonly used in the management of IgA nephropathy. We now have data on the value of endothelin receptor antagonism. So this is data from the PROTECT trial. We have the 9-month data on proteinuria reduction, and we have the 2-year GFR data now. And what this data shows is that if you add endothelin receptor antagonism on top of renin-angiotensin system blockade, you get far greater proteinuria reduction, and if the pointer works, you get a preservation of GFR. The GFR still declines, but it declines more slowly. And here you can see the proteinuria reduction is much greater than irbesartan, the comparator, and is maintained throughout the study period, with a reduction in clinical endpoints here. And the drug is well tolerated. It does drop blood pressure, and so the commonest side effect in the trial was hypotension. We might have MRAs. We need to wait and see what fine CKD shows us. And the list goes on. We may have GLP-1 agonists. We may have aldosterone synthetase inhibitors. There are new drugs being evaluated all the time. The question is going to be, how are we going to use them? Should we fill someone up with a RAS inhibitor and then see if they can tolerate an SGLT2? Can they then tolerate an ERA and then an MRA? Because the challenge with our young patients, certainly my patients, is they often have a completely normal blood pressure. And so if I give my patient all of these, they're going to fall over. So how are we going to use these? Do we just do what we've always done, which is do the RAS inhibitor first, and then slowly trickle other treatments in? Or do we consider actually giving a little of each of these, because they all do something different in the kidney? I don't know the answer to that, but that is likely to be a trial that we will need to do over the next few years to know how best to use these treatments to manage those generic consequences of nephron loss. And that's not specific to IgA nephropathy. That'll be as true in DKD as in other forms of chronic glomerulonephritis. But it's something we're going to need to think about, because our patients, unlike the large diabetics who have high blood pressure, will not be able to tolerate all of these treatments. But of course, none of those stop this. None of those stop immune complex formation, deposition in the kidneys, inflammation, leading to scarring. So we absolutely need to give treatments that target IgA immune complex-induced kidney damage. And unfortunately, until very recently, we didn't have anything really safe and well tolerated to offer our patients. So I've broken down what I think we need to achieve when we're thinking about the immune aspects of IgA. We want to turn off pathogenic IgA synthesis, just like we want to turn off ANCA in ANCA-associated vasculitis, just like we want to turn off autoantibodies like double-stranded DNA in lupus nephritis, just like we want to turn off PLA2R in membranous. We should think about IgA nephropathy in exactly the same way. We need a treatment that targets the pathogenic IgA. We also need to consider managing that inflammation that may be present when we see that patient. And just like we do in ANCA and lupus, we may, in tandem with a B-cell directed therapy, add an anti-inflammatory. We may need that, we may not. And of course, we would also very much like to turn off those fibrotic pathways that are leading to scar formation. We have made no headway in nephrology in developing antifibrotic drugs, targeted antifibrotic drugs. That is really a work in progress. In terms of managing inflammation, we have our drug systemic glucocorticoids, prednisone, prednisolone. Or if you can read, I don't know whether you can read it, I like to call them Satan's Tic Tacs, because we know they are very, very good at managing inflammation. I use them as an anti-inflammatory. My gout patients who can't take non-steroidals, I will use anti-inflammatories. They will work, steroids will work perfectly. In IgA nephropathy, they are an anti-inflammatory. There is no evidence that giving systemic steroids alters the fundamentals of the disease or reduces pathogenic IgA synthesis. So we need to be absolutely clear why we're using them. We're using them as an anti-inflammatory. And so what happens with an anti-inflammatory when you have not altered the fundamentals of the disease? Here's the testing study. What you can see here is 6 months course of steroids, reduces proteinuria, a biomarker of inflammation. What happens when you stop the steroid and you haven't altered the fundamentals of the disease? Surprise, surprise, the proteinuria and inflammation come back immediately. Now, this wouldn't be a problem if we could give patients lifelong systemic glucocorticoids, but you know that would kill them. It wouldn't be that much of a problem if we could give them repeated cycles of 6 months of glucocorticoids. That would probably also kill them, and most patients would never agree, having had one course of 6 months of steroid, to ever have another course afterwards. So this is not a viable long-term disease-modifying therapy that is going to get the disease under control, and we need to understand that when we think about wanting to use steroids. We know of all the side effects. We know certainly in the IgA nephropathy studies there were infection-related deaths, hospitalizations. We know about all the metabolic consequences of weight gain, glucose intolerance, increased blood pressure. We know about impacts on bone health. But actually what patients complain about the most is the change in their face, the stretch marks, the acne, the insomnia. And what their partners mostly complain about is the fact that they become a really irritable, bad-tempered person to live with. So I've had partners tell me that if I put their partner on another course of steroids, they're going to divorce them because they are so horrible to live with. So all of these things really matter, particularly to young people, and particularly the cosmetic side effects. The hope is that actually complement inhibition, and I think you were hearing about that in the previous lecture, although my Spanish is not great, is hopefully going to replace that. IgA nephropathy has more complement trials than any other glomerular disease at the moment, and these are all the complement proteins that are being targeted in various studies. We've had some phase 2 data reported on alternative pathway inhibition with iptacopan that targets factor B. We've had data reported on C5 inhibition with an antisense oligonucleotide, so a molecular approach designed to stop C5 production in the liver. Both show that you can effectively reduce proteinuria with complement inhibition in this disease. I don't know if anyone were at the World Congress, but there was a late-breaking abstract that went with this press release for the Applause phase 3 study. And what that showed is that in the large phase 3 registration study, targeting factor B in the alternative pathway led to a significant between 40 and 45% reduction in proteinuria at 9 months. We haven't seen any other data, but the safety data suggested that it was a very safe way of managing patients with IgA. Of course, all of those patients had to be immunized, as you would expect. We've now got our first data. This drug, iptacopan, is likely to be the first approved complement therapy for IgA nephropathy, and it's likely to be available in the United States before the end of the year. So complement therapies are coming in IgA nephropathy, and there are 3 more phase 3 clinical trials that are testing other ways of blocking the complement system in IgA as well. How do we target the fundamental problem in this disease? How do we reduce pathogenic IgA? Well, we've got two approaches. We can go for a B-cell depletion approach. That's what we use commonly in ANCA. We give rituximab. It's what we do in membranous. We give rituximab. And likely is what we're going to do in lupus when we see the results of the obinutuzumab trial. It has been used in IgA nephropathy. Rituximab did not work. It did not reduce pathogenic IgA. It did not impact on proteinuria or GFR. And that's likely because the cells producing the pathogenic IgA are residing within the mucosal immune system, not in the bone marrow, not in central lymphoid sites, which are accessible to rituximab, and which is where those autoantibody-producing cells in membranous, lupus, and ANCA reside. So this tells you something unusual that's different about IgA nephropathy. But there are other depletion strategies currently being evaluated. And so there are two phase 2 trials looking at CD38 depletion. CD38 depletion is commonly used to treat multiple myeloma. It's well tolerated. And we have two trials that will likely report later this year in IgA nephropathy. So we'll need to wait and see what that shows. We could not take a depleting approach and think about modulating B cells. And actually that's showing great promise at the moment. So we believe most of the pathogenic IgA in IgA nephropathy comes from the mucosal immune system. So that's the immune system that lines our lungs, our gut, and our genitourinary tract. And this treatment, called Nefecon, it's called Kinpeygo in Europe and Tarpeyo in the United States, is specifically designed to deliver budesonide to the terminal ileum, where it coats the terminal ileum and reduces the production of pathogenic IgA from the mucosal immune system. We've had a phase 2 study. We've had a phase 3 study that has reported proteinuria and now 2-year GFR. And this is a study that we published that looked at biomarkers from the phase 2 study, looking at the mechanism of action, showing that this approach reduces abnormal IgA in the circulation. It reduces circulating immune complexes. It reduces a pattern of chemokines and cytokines that are related to mucosal immunity. And so what this study showed was that treatment with this approach, targeting the gut production of IgA, led to a protection in the rate of loss of kidney function and reduced proteinuria. This was a trial of 9 months treatment with 15 months off treatment. And what you can see here is that when you stop the drug, the proteinuria starts coming back. So what that's telling me is it hasn't irreversibly damaged the mucosal immune system. It is not a one treatment course cure for IgA nephropathy. It is likely going to be given cyclically to patients. And the good news is that this drug is well tolerated. Because of first-pass metabolism, there is very little steroid that enters the bloodstream. It's equivalent to between 5 and 8 milligrams of prednisone. And so this drug is well tolerated. It doesn't come with all the adverse events of systemic dose steroids. And it's been shown to impact on the key pathogenic pathways in IgA nephropathy. The other group of drugs that, if you're interested in glomerular disease, are definitely going to be coming your way for a range of different autoimmune and immune-mediated kidney diseases are drugs that target the signaling of BAFF and APRIL. These are two cytokines that are essential for B-cell and plasma cell proliferation, survival, and IgA class switch recombination. And we have 5 different drugs targeting this pathway currently being evaluated in IgA nephropathy. And they're moving into membranous, ANCA, and lupus as well. But they're most advanced in IgA nephropathy. We've had phase 2 data that was presented at the S.E.N. last year for a monoclonal antibody that blocks APRIL called sibeprenlimab, and that's in phase 3 at the moment. We've had data for a different protein called atacicept that blocks both BAFF and APRIL. And that data was presented at the ERA last year, and we now have 72-week data for this approach. And what's striking about this data is that actually in high-risk patients, there is no change in GFR over a year and a half in patients who've been continually treated with atacicept. Bearing in mind we would have expected a 5 to 10 mil loss of GFR over that same period. It's early data, it's small data, atacicept is in phase 3, and the likelihood is both atacicept and sibeprenlimab phase 3 studies will report next year. So the realistic possibility is that these drugs will be available for treatment of IgA nephropathy, if they work, in the next 24 months. So these drugs are coming as well. And so this was me during most of my career when I went to the drug cupboard and I had a patient with IgA nephropathy, and I had very little, if anything, to choose. For you guys, a lot of young faces in the audience, this is what you're going to be like. These are going to be a lot of expensive drugs in here, and a lot of drugs that do things that you have never prescribed before. We have never prescribed BAFF/APRIL inhibitors or combined inhibitors. We do use BAFF inhibitors, Benlysta in lupus. But the complement inhibitors, I always like to ask, how many people in the room have prescribed and looked after a patient on a complement therapy? So not many. And that's the same in the UK. They're very, very expensive, and they're only approved for very ultra-rare conditions. These are going to become part and parcel of our way we manage IgA nephropathy in the future. So we're going to have to get comfortable with how we use them. So KDIGO at the moment tells us we start with a RAS inhibitor, we escalate the dose, we then reassess risk after 3 months of optimized supportive care, and if the proteinuria is above 1 gram, we then think about doing something different. Well, we're revising the KDIGO guidelines at the moment, and I can tell you that is going to completely change. Because while we're doing that, in patients who already have low nephron number, they're losing more nephrons. And we're not addressing the fundamental reason they're losing nephrons, which is IgA deposition. So where we're going to go is rather like ANCHOR, like lupus, like membranous, we are going to treat with maximal therapy at the very beginning of the disease, when we make that diagnosis, and de-escalate treatment once we have the disease under control. Because now we finally have drugs that allow us to do that. And so this is where I think we're going to get. You're going to have a patient who presents to you. They have a kidney biopsy diagnosis of IgA nephropathy. We are going to want to simultaneously address those generic drivers, because our patients are going to present with already having lost lots of nephrons. We have to accept that. But we are going to want to, at the same time, address those immune and inflammatory mediators. We're going to always, of course, do all of these things. We've got RAS inhibitors, SGLT2s, we've got sparsentan. That's likely to be approved by the European Union anytime soon. So sparsentan is going to be available for you guys. I'm not sure how much it's going to cost, but that will be an issue. But there is going to be available for you. And then we've got other agents that are coming. We're going to want to think about how we address the immune-mediated aspects. We're going to want to reduce inflammation if it's present on the biopsy. We're going to want to reduce pathogenic IgA. The drug we have that we know does that at the moment is Nefecon, Kinpeygo, but we've got all these others that are likely to be coming in the near future. From an inflammation point of view, we really only have systemic steroids. I would have loved to have seen avacopan taken forward in IgA nephropathy. I think that's a great drug as an anti-inflammatory. There was a small open-label study that did show benefit, but it was never taken anywhere further forward. But we now have iptacopan. But just a note of caution. Iptacopan has been licensed in the United States for the treatment of paroxysmal nocturnal hemoglobinuria. It is $500,000 per year. So that kind of puts into perspective, we may suddenly have all these drugs available, but they may well be unaffordable for the vast majority of patients. We need to wait and see. But complement inhibitors are coming as well. I would love to finish off by telling you there are 5 blood and urine tests you need to do. that tell you which drug to give to which patient and when to stop it, but we don't have those biomarkers. All we have is proteinuria, GFR, hematuria, and that's it, I'm afraid, at the moment. But we are working very, very hard to find biomarkers that will help us decide which of these agents we're going to choose when they all become available. So this is my last slide. I hope I've convinced you that the future in IgA is incredibly exciting. And normally in a room of nephrologists, I tell the nephrologists to forget about dialysis and transplant. And if you want to develop your career, concentrate on glomerular disease. But you're already here, which is fantastic. But I think the real challenge is going to be how we use these drugs, how we combine them, and what is actually affordable for us to use, because these are not going to be cheap. So thanks very much for your attention, and I'm happy to take any questions.
Thank you very much, John. Excellent and authorized, comprehensive lecture. We have now time for questions for Professor Barratt. I have the first question. So, do you recommend to initiate treatment, you say, with CKD treatment, no? With antiproteinuric drugs, and at the same time to target the pathogenic pathways of the disease. But some patients achieve an important proteinuria reduction only with conservative treatment. So perhaps we need a more discussed definition of complete and partial remission in IgA nephropathy in a similar way like membranous nephropathy, nephrotic syndrome. What do you think about this?
I completely agree. I think the real challenge we're going to face is if we use hemodynamic treatments to reduce proteinuria, how useful is proteinuria as a biomarker of ongoing glomerular inflammation? If I fill my patient up with a RAS inhibitor and an SGLT2 inhibitor, possibly an ERA, and drop their glomerular filtration pressure, and their proteinuria comes down beautifully, what else have I got to know how much glomerular inflammation is going on? And don't forget, I showed you data where 1 in 4 people ended up on dialysis after 10 years who had between 0 and 0.5 grams of proteinuria. And complete remission would largely be thought of as less than 0.3. So we need to understand what the limitations are of our biomarkers. So yes, I can hemodynamically reduce proteinuria beautifully, but then does that lull me into a false sense of security that actually everything's okay? And I'm not really understanding what's going on in terms of an inflammatory loss of nephrons. That really concerns me in terms of what we will do with CKD treatment, which is all great, cardiovascular stability, but it will really potentially nullify the ability of proteinuria to be a sensitive marker of glomerular inflammation. And that's a worry. So this is where things like soluble CD163 may come in terms of helping us with that. But that's just something we need to be cautious about when we're just focusing everything on proteinuria.
Yeah. Dr. Caravaca?
So beautiful presentation. It was really encouraging. And I have actually a couple of questions. First one is that one of the caveats of many of these trials is that the new agents are not compared to an active comparator, so it's just compared to placebo. So would you expect, once we have the possibility of prescribing these new agents, would you expect similar results compared to what we actually do in clinical practice, at least in Spain? I mean, using corticosteroids, mycophenolate, would you expect similar results, for instance, with the use of target release budesonide?
So I think we need to go back to what we're giving the drug for. So I completely agree. The trial design of a placebo-controlled trial in IgA nephropathy is now almost inconceivable because we have drugs. And actually part of the KDIGO work we're doing is thinking, what would a clinical trial look like in 5 years' time? I think what I think we need to be thinking about, if you're giving systemic corticosteroids, then you're giving an anti-inflammatory. So if you want to compare its effect, compare it against another anti-inflammatory. You would never compare steroid against rituximab in ANCHOR, would you? Because they're designed to do two completely different things. And this is where we need to get our mindset completely changed in IgA. The steroids that we use in IgA are there as an anti-inflammatory. They're not altering the fundamentals of the disease. There is no evidence for that. And so if you want to compare them against another anti-inflammatory. But I would also challenge you, if you look at the way we manage far more inflammatory diseases like ANCHOR and class 3, class 4 lupus, what have we been doing with steroid doses over the last few years? We have been lowering them and we have been shortening the duration with rapid taper. We don't give 6 months of 40 milligrams of prednisolone to anyone with those conditions, do we? And we know why we don't, because it's poorly tolerated, it comes with side effects, and we're giving a therapy to target the production of pathogenic immunoglobulin, be that rituximab, mycophenolate, cyclophosphamide. That is the mindset we need to move ourselves into in IgA nephropathy. So if I was going to say, I don't know whether I can go back, but if I was going to say what clinical trials will look like, I will want to compare a BAFF/APRIL inhibitor against Tarpeo, Nefecon, because they're both designed to do the same thing. I will want to compare iptacopan against steroid. They're both doing the same mechanism. That's how I would be thinking about comparing.
Thank you. And the second question is, do you have any clue on why narsoplimab failed on IgA nephropathy? I mean, you were involved in the initial trials and the result. Do you have any data? You can provide us. I mean, we are almost everyone, we are physicians, no industry at all.
So I still have no doubt the lectin pathway is important in a proportion of IgA patients. I have spent the last 6 months, at least one night a week, going through the data with Omeros. And I can't really say anything more than that, other than we are identifying reasons why the trial did not work, that are nothing to do with the fact that the lectin pathway isn't important. I think it is. There were other things that were needed to be addressed. And that will all come out. But I still think if we can effectively target the lectin pathway, then we will help manage a proportion of IgA nephropathy patients. The interesting thing is, in some work that we've done, is if you look at specific complement fragments in the kidneys at time of biopsy, there's C3 there in 95%, but that can be covalently bound and have been there for 6 months. Actually, in only a proportion of patients at the time of biopsy is there evidence of active complement activation when you look at specific fragments. And then of those, a proportion have lectin, a proportion have alternative, a proportion have both. So I think we really do need to think, and of course all the complement trials, biopsy 5 years ago, don't actually have to have evidence of complement activation to get into a trial of a complement inhibitor, which is mad, you would think. So I think we're going to need to think very carefully about how we use the kidney biopsy, particularly when we're thinking about complement inhibition, because there is absolutely no point spending hundreds of thousands of pounds, dollars, euros, on a drug to treat complement activation when there's no evidence in the kidney it's actually happening. So I think there's a lot of work to be done there in terms of how we better utilize complement therapies, because complement is only one aspect of glomerular injury. It's not like C3G or aHUS, where it's virtually every aspect. It's one aspect, and it's not activated all the time.
Yeah, so in this regard, I was wondering whether the inclusion criteria used, particularly just a well-preserved EGFR together with a proteinuria about 1 gram, whether that proteinuria might not be related directly to the disease, but rather could be just hyperfiltration, like chronic damage, and therefore...
Absolutely. Proteinuria is the best we've got, but it could be driven by inflammation, it could be driven by active nephritis, it could be driven by chronic scarring and podocyte damage with no inflammation. And that's a real challenge. The fact of the matter is, if we had only taken incident patients and used the kidney biopsy to include in clinical trials in IgA nephropathy, we wouldn't have finished any of them by now, because it takes so long to recruit. So there was a degree of pragmatism that we wanted patients in, And we knew that some of those are probably not going to have active disease. The job, once we've got the drug, is to then work out which is the exact group. And actually, one of the things that's a real challenge when we talk to pharmaceutical companies is saying, actually, what I'd really like to do is look at your data to see who really did respond and who didn't respond. Because that, as a clinician, is what I want to know. Of course, pharmaceutical companies don't necessarily want to know who didn't respond, because that limits their market. So there is a tension here, but it's something that the steering committees are really looking at in terms of who are the people that really did respond, that justify that drug with those risks and the financial cost of using the drug. And we hopefully will get there, but it won't be quick.
Thank you so much.
Another question, obviously we will need treatment algorithms with this plenty of new treatments to select the most appropriate treatments. And you know that our group and other Spanish group are quite obsessed with hematuria. Recently, the Mayo Clinic group, Fernando Fervenza, published an algorithm. I like very much this algorithm because it includes the presence or not of hematuria to select CKD treatment or autoimmune targeted therapy. What do you think about it?
So mechanistically, it makes perfect sense, but there are some key challenges. I would challenge anyone to look at the urine of a patient with Alports and the urine of a patient with IgA nephropathy and distinguish the two between them. One may have inflammation, one has no inflammation. They have a damaged glomerular basement membrane. Now, the reason that glomerular basement membrane is damaged can be multiple reasons. I would also say that there are a lot of patients who have IgA nephropathy that we don't biopsy anymore, who have significant non-visible hematuria. And we don't biopsy them because there's no risk of progression. Yeah. So I can't square the fact as how hematuria adds value. The thing that would concern me in someone with non-visible hematuria is if they develop proteinuria. I wouldn't treat that non-visible hematuria. So what does that indicate compared to non-visible hematuria in a different IgA patient? I can't distinguish them. They would all have dysmorphic red cells. Red cell casts, yes, in the setting of an RPGN, but actually there's a disconnect between non-visible hematuria and glomerular inflammation, glomerular basement membrane damage in type 4 collagenopathies, and in those patients that just have non-visible hematuria and have no risk of future kidney damage. And that's where I really struggle to see the importance I would put. And I'm sure that it does signify glomerular inflammation in some patients, but I just can't tell between them.
Okay. Luis.
Okay. Thank you, John, for this inspiring talk. I want to challenge you because when we take a patient with lupus or vasculitis under remission to get a transplant, the risk of recurrence is very low, but it's not the case for the IgA patients. So it's all about autoimmunity, control inflammation in the IgA very severe patients. What do you think about it?
I think that speaks perfectly to the fact that the traditional drugs we use in ANCA and lupus don't work in IgA nephropathy. Cyclophosphamide, azathioprine, MMF, at least in European patients. That's because the cells that are driving the disease are not sat in the bone marrow, in central lymphoid sites. They sit in the mucosal immune system. The mucosal immune system does not drive rejection. The tablets that are used to treat autoimmune diseases or to manage rejection episodes are not designed to target the mucosal immune system. So that's why I think there's a disconnect. And I think, so one of the things, certainly it's one of the things I'm getting asked about the most is recurrent disease. And thinking about those people who've already lost one graft or perhaps are losing their second. And I think there's an opportunity here to use therapies like gut-directed steroids, like Kinpeygo, to manage both the systemic risk of rejection, because there's a 5 to 8 milligram systemic dose, but also manage the production of pathogenic IgA. So I think it speaks to the fact that drugs that we traditionally think of as immunosuppressives that are good for transplant rejection, They're good for managing certain forms of kidney disease, but have failed to work in native disease, and failed to work to prevent recurrent disease. And that tells us something fundamental about the immunology and where these cells are located and how they behave. And that's why we need a different approach.
Thank you very much.
Well, no more questions. Thank you very much again, John, for this fantastic lecture.
Thank you.